Obtain intubation consent. Prepare the baby's bedside as you would for routine intubation, making sure the suction catheter is working, the ambu bag is available with the appropriately sized mask, and that equipment for intubation if needed is available. If clinically indicated, load the baby with caffeine before LISA and give the baby any intubation pre-meds if ordered by the provider. If the baby has an OG tube already in place, aspirate prior to the procedure to vent. If the baby does not have an OG tube, you do not need to place one prior to LISA. Create a sterile/clean field using sterile drapes on the airway cart and to the right of the baby. RT will scan the surfactant barcode to verify surfactant dosing with the MAR on Epic, and the RT will draw the required surfactant dose plus an additional 1 ml of air into the syringe. Air in the syringe will be used to flush the catheter once the surfactant has been delivered into the infant's trachea. RT will open and drop the 16-gauge angiocath, open and drop the tegaderms, and drop the pre-cut tape measure and the pre-cut ET tube tape onto the sterile field. ET tube tape is technically not sterile, but try to maintain as much sterility as possible on the rest of the field. Using sterile gloves, the RT will cover the entire tape measure with tegaderm to create a sterile barrier. After creating the sterile barrier, remove the needle from the angiocath and throw it away. Place the angiocath on the tegaderm tape measure with the catheter tip of the angiocath at 0 cms. Wrap the ET tube tape around the angiocath at the target depth. The RT will place the laryngoscope and any additional required equipment on the clean field to the right of the provider. Perform a pre-procedural pause for intubation and LISA, confirm the surfactant dose, leave the baby on non-invasive support while performing LISA, and avoid PPV if possible. Using sterile gloves, the provider will insert the laryngoscope to visualize the vocal cords. Once the vocal cords are visualized, the RT will hand the angiocath to the provider. The provider will advance the angiocath until the ET tube tape on the angiocath aligns with the patient's gums. The provider will remove the laryngoscope while holding the angiocath securely against the baby's upper gums. While the provider maintains angiocath position, the RT will administer surfactant in 2 aliquots, delivering the full dose in less than 1 minute total. Hold the syringe upright so that the 1 ml of pre-filled air rises to the top. After surfactant is delivered, flush the angiocath with the remaining 1 ml of air in the syringe. At the completion of LISA, the provider will remove the angiocath. Keep the baby's mouth closed. Some refluxing of surfactant into the oropharynx is expected. If surfactant refluxes out of the mouth, use a gloved finger to try and sweep it back into the mouth.